Well, hello everyone. I'd like to welcome everyone to today's AHRQ webinar, which is the second part of a webinar series on health information exchange. Although a few people are still logging in, we are going to go ahead and get started on time. As Connie mentioned, my name is Ed Lomaton, and I will be moderating today's webinar. I currently serve as a medical officer in the Center for Evidence and Practice Improvement in the Division of Health Information Technology at AHRQ. Before we get started, I'll go over a couple other housekeeping items, and then we'll get right into the presentation. We will be recording this webinar, as you heard, and the recording will be available via the AHRQ Health IT YouTube channel in about 2 weeks. Copies of the PowerPoint slides were emailed to each of you earlier this morning, and we were also available for download as you logged in today. We will also be sending them to participants via email following the webinar. We are pleased to have with us today an esteemed group of presenters. They include Dr. Molly Cummins from the University of Utah, who will lead the first presentation today, Dr. Jason Shapiro from the Icahn School of Medicine at Mount Sinai, who will present his research second, and finally, Dr. Joshua Vest from the Indiana University Richard M. Fairbanks School of Public Health in Indianapolis, who will present his research last. This webinar event is accredited by Professional Education Services Group, and for those of you who are interested in receiving continuing education credit for participating in this activity, information about how to claim your credit will be presented at the end of the presentations. It will also be emailed to you after this webinar. For the purposes of accreditation, let me note that neither the presenters nor the sponsors of this event have any relevant financial interests to disclose, and no commercial support was received for development of this learning activity. Dr. Shapiro would like to disclose that his spouse is an in-house attorney at Purdue Pharma. Just a brief note about questions. We have reserved time at the end of the presentations to address participant questions. However, during the presentations, feel free to submit questions that you have for the presenters using the Q&A panel located on the right of the PowerPoint slides. As a reminder, participants are in a listen-only mode, so to ask questions, you will need to use the Q&A panel. As I mentioned a moment ago, today's webinar is the second in a series of 2 webinars that AHRQ is hosting on health information exchange. The overall goal of today's webinar is to share research activities around the use of HIE to support collaboration and promote care improvement in health organizations. The first webinar in this series was held last month on March 16th and included presentations about the current challenges and possibilities in exchanging health information electronically. If you missed this activity and are interested in viewing the webinar, you can go to the AHRQ Health IT website, where it is now posted along with the slides. This slide shows the learning objectives for today's webinar. By the end of the presentation, you should be able to, 1, discuss the potential effects of health information exchange-driven process models and advanced informatics tools to improve communication between emergency departments and poison control centers. 2, describe the development of an HIE-based tool to support new e-quality measures used among multiple hospital systems for ED returns and frequent users. And 3, explain the implications of how HIE services are defined geographically. And now it is my pleasure to introduce our first presenter, Dr. Molly Cummins. Dr. Cummins is an associate professor of nursing and an adjunct associate professor of biomedical informatics research at the University of Utah, where she co-directs the nursing informatics program. Prior to her career in informatics research, she practiced as an emergency nurse and a family nurse practitioner. For the past 11 years, she has partnered with the Utah Poison Control Center to study informatics issues and innovations related to poison control. This work has resulted in multiple awards, including awards from the American Medical Informatics Association and the American Association of Poison Control Centers. She is currently leading an AHRQ-funded study related to health information exchange between emergency departments and poison control centers. Now it's my pleasure to turn the control over to Dr. Cummins.
I'm going to talk about Thank you. Today I'm going to talk about how my team at University of Utah is using health information exchange to make data move and matter for poisoning. The research activities I'll describe in this presentation are funded by AHRQ, and I'll also describe some related work that's funded by the ONC. At the end of this presentation, you will be able to describe the Utah model for HIE-supported collaboration during emergency management of poison exposures. You'll also be able to describe our use of standards to support bidirectional HIE between emergency departments and poison centers. And finally, you will be able to describe the importance of workflow integration in applications of HIE. So the work that I'll describe today is the product of a strong regional effort with multiple organizational and individual contributors. The collaborating organizations include the Utah Poison Control Center, the Utah Health Information Network, Intermountain Healthcare, and specifically Intermountain's Homer Warner Center for Medical Informatics. I've also listed some members of our team. This is a highly interprofessional team. It includes informaticists, nurses, pharmacists, physicians, software engineers, statisticians. It's a diverse group, and this large team is focused on fully leveraging health information exchange in relation to poisoning. So poisoning is the leading cause of unintentional injury death in the United States. It exceeds motor vehicle crashes, and it's one of the top 10 causes of non-fatal injury requiring treatment in emergency departments. To give you a sense of the scale, over 2.1 million human poison exposures were reported to United States poison control centers during 2014 alone. And over 28% of those, nearly a third, were managed in a healthcare facility. That's a substantial proportion. The number of poisoning fatalities in the United States has increased substantially in recent years, and that increase is widely attributed to prescription drug abuse. However, there has also been an increase in non-fatal emergency department visits related to prescription drug exposures, including children who gain access to a variety of prescribed drugs in the home. As our bathroom cabinets store more medications for chronic illness and pain, it simply creates more opportunities for abuse, misuse, and accidents. We are particularly concerned about poisoning here in Utah, where, as you can see, our death rate due to poisoning has been among the highest in the nation. U.S. poison control centers are on the front lines dealing with this threat. They function as a call center. They field telephone calls from both the general public and healthcare providers. The specialists who staff the phones in these centers are primarily nurses and pharmacists with very specialized education in toxicology. They actually take a full history, they assess the exposure situation, and they make specific recommendations, whether it's to a caller or to a healthcare provider. They determine whether the exposure can be managed at home or whether the caller should go to an emergency department for further evaluation and treatment. They also consult with the emergency department, care providers, physicians, nurses on any poison exposure case that walks through the door. And they provide recommendations for monitoring and treatment. And they continue to follow the cases beyond that initial consultation. They monitor the patient's progress, they look at their lab results, look at the effectiveness of treatments that are administered until that exposure is considered fully resolved. And sometimes that involves following these patients from an initial call through a hospital admission back to the home. Most poison exposure cases involve no effect or minimal effect. And so poison centers perform an important gatekeeping function. They keep the worried well out of emergency departments. And in doing so, they save the U.S. healthcare system enormous amounts of money each year. However, a substantial and increasing number of cases, as I previously described, require further evaluation and treatment. So how do poison control centers manage the data and information that's associated with this entire process? They use a case-based poisoning information system, of which there are several available. Toxicol, a proprietary system, seems to be the most widely used. And for public health purposes, this data is used for epidemiology and surveillance. All U.S. poison control centers contribute standardized data to the National Poison Data System. That's a database maintained by the National Association of Poison Control Centers. For some other public health purposes, they might email PDF case summaries or they may fax information. But for providing consultation to emergency department care providers, they rely almost entirely on telephone and fax. So let's take a closer look at the use of telephone communication to support this process. Telephone can be useful. It enables highly expressive verbal communication. It is very low cost and it requires little to no configuration. You just pick up the phone and dial. However, studies of healthcare environments also show that there is a high risk for error in verbal communication. Case-based data in the poison control setting indicates that telephone communication is fragile in disaster scenarios because as the calls start pouring in, the lines become saturated, and the poison center prioritizes new exposure cases that have not been assessed over the ED cases where a patient is under a licensed healthcare professional's care. So the ED cases become a much lower priority in those situations. On the ED side, telephone calls are a known and persistent source of interruptions, and those interruptions can lead to safety issues. With funding from AHRQ, previous funding from AHRQ, we studied 120 telephone calls between emergency department and poison control centers in detail. We analyzed the calls to assess their information content. However, we also looked at inefficiencies and safety vulnerabilities, and this study was published in Clinical Toxicology. I've listed all these references at the end of the presentation. We found that multiple telephone calls between the ED and the poison center occur as poison exposures unfold. And those calls, as you might imagine, are always between two people, a dyad. For example, an ED physician talking to a poison center pharmacist, or an ED clerk and the poison center pharmacist. There is no shared documentation to reference as they communicate about a case. We noticed that the poison center specialist frequently has difficulty reaching the appropriate care provider, and sometimes they resort to the exchange of clinical information with non-clinical staff. They end up talking to the clerk, essentially. They're often unable to get the information they are seeking. For example, they call to check on a patient's lab results, but can't get the information because it's not yet available, or they just can't get the right person on the phone. And instead of describing actual lab values, the lab values are characterized as fine or normal, which toxicologists will tell you is inadequate. Often the patient is discharged prior to any successful synchronous telephone communication between the ED care provider and a PC specialist. On the basis of this and other pilot work, we proposed to develop a health information exchange-supported collaboration process. In a 5-year study, we are developing a model process for this HIE-supported collaboration. We are developing and implementing crucial informatics tools to support the process, including new software that allows poison centers to participate. And in the final aim, we are evaluating the effects of the process and the tools on workflow, communication, efficiency, and utilization of the poison center services. Our vision entails bidirectional health information exchange. So as a poisoning event unfolds, there is ongoing information sharing back and forth between both the emergency departments and the Poison Control Center. We want the entire process to be standards-based so that process is replicable and supports broad interoperability of the poisoning data. We are not eliminating the telephone. We are offloading the sharing of data and information to health information exchange, but when complex case discussion is appropriate or there is a need to break the glass, the telephone is still available. And with this grant, we want to do more than make the data move. We want to make it matter. And making data matter means that you don't just make the data accessible, you actually integrate it into the healthcare provider workflow. You call it to their attention at the point of decision making. In our process, we are using HL7 C-CDA documents to support information sharing. This is our standards-based approach. And we've detailed this in an article that we published in JAMIA last year, first authored by Guilherme Del Fiol. We've developed software that allows a poison center specialist to create and send a C-CDA consultation note. The note is sent to the emergency department when a poison center refers a patient and can also be used to provide updated recommendations as a case unfolds. The emergency department will be sending 3 types of C-CDA documents to the poison center: the referral note, progress note, and discharge summary. The process of sending these documents is largely invisible to the ED care provider. I'll talk more about that in a minute. When the poison center refers a patient to the emergency department, the referral populates the pre-arrivals in the emergency department tracking system, which is a kind of electronic whiteboard that the emergency department uses to track its patients. There they have one-click access to the full consultation note, a note that contains a summary of the case and the patient and includes initial treatment recommendations. The process is partially automated. The Utah Poison Control Center staff will use specialized software to create and send outgoing C-CDA consultation notes, and they'll use the same software to monitor incoming communications. The ED can request automatic poison center consultation on the basis of select coded chief complaints, but the process can also be manually triggered from within their ED tracking system, just a click. The process of sending the other C-CDA document types from the ED to the poison center, so I'm talking about the progress note and the discharge summary, is fully automated, and that's invisible to the ED care provider. It doesn't require a physician or a nurse to take any action at all. This all has implications for workflow, important implications. On the Poison Control Center side, there is a substantial change to workflow. We're introducing new software and processes for managing calls, and we expect that specialists will spend less time on the telephone, but more time on electronic documentation. However, given that the emergency department cases comprise a relatively small percentage of their overall caseload, our simulations predict a negligible overall impact. It's something that we'll be watching carefully as we move forward. On the ED side, this process should virtually eliminate telephone interruptions, and in many cases, physicians and nurses will have the initial treatment recommendations from the poison center in hand before they ever walk into an examination room. As an example, let's take a closer look at just one part of the overall collaboration process. That step when the Poison Control Center refers a new case to the emergency department. Right now, the Poison Center specialist places a telephone call to the emergency department, and they'll reach a charge nurse, a triage nurse, or whomever is available at that moment. The Poison Center tells the ED about the case, who is coming, what they recommend in terms of initial evaluation and treatment. some subset of that information is written down, usually on a Post-it note or a paper form, whatever's handy, and that piece of paper may or may not ever reach the clinician who sees the patient. And what I've described seems to be very representative of the process used at most hospitals. In the new process, the Poison Center won't place that telephone call. Instead, they'll send an HL7 C-CDA, and the patient will be displayed under pre-arrivals in the ED's tracking system, that electronic whiteboard. The emergency department personnel can then click to view a full consultation note with summary and initial treatment recommendations. And what a difference from a scrap of paper to a C-CDA. The C-CDA offers much more detailed and concrete information and recommendations. And although we've remained compliant with the HL7 standard, we are using HTML formatting to present the information within the sections according to preferences expressed by our emergency department collaborators. And the C-CDA, integrated with the tracking system, is visible to each and every member of a patient's care team in the emergency department, not just the one person who happened to take the telephone call. So for those of you familiar with HIE, we're using both direct and XDR to manage the overall health information exchange process. And we've completed successful end-to-end testing of transmissions from the Poison Center to Intermountain. We did that testing back in December. The Utah Health Information Network plays an important role in mediating and routing these messages. And Intermountain Healthcare, Sid Thornton's team, has developed an approach to managing the messages and integrating them with the ED tracking system. And in some additional related efforts funded by the Office of the National Coordinator, we are implementing a modified version of the process that will scale to all Utah emergency departments. And it will also enable the sharing of C-CDAs with the Utah Department of Health, and that's for use in an environmental exposure database. The technical work underlying this project is considerable, and it's based on substantial preliminary work that identified information requirements, process characteristics, other considerations. In addition to developing the standards-based approach, we also designed a C-CDA consultation note for the poisoning use case. We engaged clinicians in that process to make sure the note meets their needs. Our able PhD student, Ali Khalifa, did the work of mapping data fields from the Poison Center's information system to the C-CDA consultation note. And our Poison Center uses Toxicol, and we did so with the blessing of Toxicol. And software engineers Pallavi Renaud and Andrew Iskander, among others, implemented those artifacts within software that allows the Poison Center specialists to create, receive, and monitor the HIE communications. The work is incredibly interesting from an informatics perspective because poisoning is such a unique use case. Patient discovery, for example, this is very basic in any health information exchange process. Patient discovery isn't possible on the basis of the data currently collected during calls to the Poison Control Center. We've had to actually modify the nature of the information collected by the Poison Center to enable successful PD calls. Poison Center information systems generally store case-based data. It's unlinked to unique patient identities. It's a way of storing patient data that's very common in public health, but it's less functional for clinical purposes and certainly less functional for HIE. And since Poison Centers do not bill patients for services, they normally don't collect the type of patient identifiers that you find in healthcare settings. So this new HIE process is changing that. We've completed some very interesting analyses of coded chief complaints in relation to poison exposures that we'll soon be publishing. We explored that data as the basis for defining our automatic triggering strategy for initiating referrals on the emergency department side. and we'll be publishing that soon. And we're also working in tandem. All of our work on this project has been in parallel with the implementation of Cerner at Intermountain Healthcare. And so we've had to remain flexible and work with those changes, adjusting our timeline. So never a dull moment on this study. We're studying the process that I'm talking about, the bidirectional workflow integrated HIE process at 2 Intermountain emergency departments using a pre-implementation, post-implementation design. We're implementing on the Poison Center side later this year, and we are planning emergency department implementation in early 2017. And we're studying various measures of workflow and communication, efficiency, and utilization of services, the Poison Center services, and we're also evaluating the tools we've developed. As I mentioned earlier, we're developing a modified low-barrier version of this process that will be available to all Utah emergency departments, and that's with funding from the ONC. We are subcontracted to the Utah Health Information Network. The Poison Center will send a C-CDA on all emergency department cases, and that will be stored in our community HIE where it can be accessed by any healthcare provider, whether an ED care provider or a patient's primary care provider 2 weeks later on a follow-up visit. It can be more tightly integrated with workflow at the hospitals, but that's really dependent upon the hospitals and their capabilities and their allocation of resources. The consultation note will also be used to build an environmental exposure database at our State Department of Health. So the same data is supporting both individual patient care and public health. And that's the idea, isn't it? When we can share data across boundaries in support of patient care and integrate it with workflow, we are ensuring that complete and relevant data is available to the healthcare providers at the point of decision making. The data moves and matters. And once we're moving data fluidly across boundaries, we can aggregate it and learn from it in order to understand how to better treat poison exposures. We don't just use data for an immediate care need. We use it to learn, to improve, and also to support public health. I've included some references for the material I presented today, and I look forward to answering questions later in this webinar. I've also included my email address, and I welcome you to contact me with any additional questions. Thank you.
Thank you very much, Molly. As a reminder, as Molly mentioned, we'll be taking questions after all 3 presentations, so please submit any questions you have for Dr. Cummins using the Q&A panel. And as we get ready for Dr. Shapiro's presentation, let me introduce him. Dr. Shapiro is Associate Professor in the Department of Emergency Medicine and Program Co-Director of the Master of Science in Biomedical Informatics in the Graduate School of Biomedical Sciences at the Icahn School of Medicine at Mount Sinai. Dr. Shapiro conducts informatics research focusing on health information exchange, emergency medicine, public health, and health services. Dr. Shapiro's work has been funded by the Agency for Healthcare Research and Quality, the National Library of Medicine, and the Centers for Medicare and Medicaid Services. Current projects include the creation of a frequent ED user notification system, detection of duplicate and potentially unnecessary CAT scans using HIE data, and designing algorithms to identify potentially undomiciled patients from demographic data in the HIE. And now I'd like to turn it over to Dr. Shapiro.
Okay, thank you very much. I'm very glad to be here to present the work today that was funded by AHRQ, and I'm going to be talking about health information exchange empowered frequent ED users and early ED return cases. Again, this work has been funded by AHRQ, and I'm very glad to have had the opportunity to present it here. So first, I just wanted to describe a little bit of my laboratory, which is this Health Information Exchange in and around New York City, HealthX, which was formed by the merger of three smaller HIEs, NICLIX, which was mainly Manhattan-based, LIPIX, which was mainly Long Island-based, and BHIX, which was mainly Brooklyn-based. The current Health Information Exchange has more than 16 million unique patients and comprises 211 participating organizations with more than 600 facilities and more than 35,000 acute and extended care beds. There are more than 12,000 users doing more than 10,000 patient searches per month. And actually, I just saw data yesterday. There's well more than 80,000 alerts or notifications delivered across the Health Information Exchange monthly. So I just wanted to sort of set the stage and really talk about a necessary precursor. It's kind of an obvious one for Health Information Exchange or interoperability to really be useful, and that is patient crossover, which is really anytime a patient visits more than one site and causes fragmentation of their medical information or their health information across the various silos of data that might exist in any region. And then just to show some examples of this crossover, these are preliminary data that we had from the NICLIX system looking across just 5 sites that had EDs. And this was looking at all comers, patients who came into the ED, how many of them had data available at one of the other 4 sites. And it was about 19% of ED visits. And then this is another slide that I like to show, and this shows of the 12 sites that participated in NICLIX, the smaller HIE, how many patients visited 2 sites, 3 sites, 4 sites, and so on. And as you can see, there's one patient who actually managed to make it to all 12 sites that were participating in this HIE. And I'm going to show data from the larger HealthX HIE that's similar in a few moments. So the focus of the work under the grant from AHRQ is to look at frequent ED users and at early 72-hour ED returns. So frequent ED users, the ultimate goal of the award is to build a frequent ED user notification service, and we currently have this implemented and are validating the data. I'm receiving notifications daily. So when a patient comes into the ED at our site at Mount Sinai for their incremental 4th visit within 30 days, an automated notification is generated by the HealthX HIE and is sent across as a standard HL7 2.x message to our site, and then is going to be sent on to case management resources to try and go in real time and interview the patient and try and see if there are other resources that might be made available to reduce the patient's recidivism. The second arm of the work is to look at early 72-hour ED returns. And we're currently using 72-hour return reports in our own data from our own hospital and have been for many years now to look for, as part of a continuous quality improvement program. So we look at patients who are discharged from the ED and return to the ED within 3 days. We look at the initial visit to see if there were any issues with the quality of care. So first, looking at frequent ED users. Frequent ED users, the most common definition are patients who have 4 or more visits within a year. They comprise 4.5% to 8% of all ED patients, however, account for 21% to 28% of ED visits. They tend to have more social, psychiatric, and substance abuse issues. They are sicker with higher acuity and more complex conditions. They're admitted to the hospital more frequently, incur higher costs, have higher mortality rates, and are not typically uninsured, but are often underinsured participants in government payer programs. And their visits are often not limited to a single institution. So I'd like to present some data that we published in an article at the end of 2013 as part of this study. These data are from 10 EDs participating in NICLIX over a 1-year period. In this, we found that there were 920,000 ED visits by approximately 590,000 patients. And we looked at ED super users, so not 4 or more visits within a year, but 4 or more visits within 30 days. We identified 4,700 patients looking just at site-specific data, so not looking across the whole HIE, but looking at each individual hospital's data. When we then looked across the entire HIE, so they could have 4 or more visits at any combination of the EDs, that number increased to approximately 5,700. We then looked at the visits that comprise these frequent ED visits, and we found 45,000 visits using site-specific data, which increased to 53,000 when we looked HIE-wide. So this accounted for a 20% increase in our ability to identify frequent ED visits and a 16% increase in our ability to identify frequent ED patients. 29% of the patients who were these super user frequent ED users had crossover visits compared to only 3% among regular ED visitors. That's a 9-fold increase in crossover among frequent ED users. You know, one of the things with HIE and interoperability is trying to target populations of patients that are most likely to benefit from these interventions, whether it's a disease-specific cohort or, in this case, potentially patients who are frequent ED users, because they tend to have data that's spread out across multiple provider organizations more commonly. So then looking at crossover among frequent ED users, this is another study that we are going to be presenting at a conference next month. These are data from HealthX over a 5-year period. We identified over 8 million ED visits by over 3 million patients, so it's a much larger data set. And again, we looked at the number of patients who had visits to 1 ED, 2 EDs, 3 EDs, and so on. And similar to that previous table I showed, there were 31 EDs in this current study, and we actually had 1 patient who made it to 29 of those 31 EDs over the 5-year study period. Frequent ED users visited 73% more hospitals than standard ED users. There were 205 patients with 10 or more that visited 10 or more hospitals, 11 who visited 20 or more hospitals. We had 409 patients with more than 100 ED visits during the study period, 44 with more than 300 visits, and we had 1 patient who had 987 ED visits during the 5-year study period. And then we also looked at what would happen. One of the hypotheses was that when we went from a smaller health information exchange to a larger one, we would improve our ability to identify patients using these measures. And that is what we found with regard to frequent ED users when we went from the 10 sites participating in the smaller NICLIX health information exchange to the larger HealthX health information exchange. There was an increase of about 6%. So now turning our attention to early ED returns, 72-hour returns. It's under widespread use as a marker for high-risk patients, as I mentioned, in CQI type processes. However, it's really not a good overall quality measure to say this emergency department's doing a good job or this emergency physician's doing a good job versus that one, because there's a large amount of variation among environments depending on things like payer mix. As you can imagine, if you're in a community with a lot of patients with commercial insurance who have primary care providers, it's easy to arrange for follow-up for them on repeat visit with their primary care providers, whereas in other places where they might not have as good access to primary care, patients often wind up coming back to the ED a lot of the time for scheduled visits for things like wound checks and other things. So in early return patients are not necessarily sick or admitted more frequently. So then looking at a similar analysis that we've completed on 72-hour ED returns, and this was just recently accepted for publication in Academic Emergency Medicine and should be available soon, we found that there were about 12 million encounters from 31 EDs in HealthX, and we identified 544,000 patients using just site-specific data where the patients are discharged and returned to the same ED. And when we expanded it to the entire 31-site HIE, that number increased to 606,000. And similarly, looking at the visits, that number went from 848,000 to 955,000. And this accounted for an 11.4% increase in patients that we were able to identify when we looked across the whole exchange, and a 12.6% increase in visits that we were able to identify. For the 11 hospitals, and then when we looked again, going from the smaller HIE to the larger HIE, we were actually able to increase our ability to identify 72-hour return visits by almost 75%. So this shows value in further aggregation of nodes on the network, if you will, to larger collaborations where health information exchange data is being shared. So how can health information exchange help, and what is HIE really offering for the first time? It's a real-time community-wide data set. We've had for a long time administrative data sets and claims-based data that allow us to look across provider organizations, but those often come with long lag times, or they use sampling methodologies, so they don't really lend themselves well to putting in place real-time clinical interventions based on the data that crosses organizations. And this really lends itself to secondary use cases, things like care coordination, quality measurement, research, population health management, and predictive modeling. So I'm going to just talk briefly about clinical event notifications, which is really the thing that is empowering the frequent ED user part of this project. And most of these have been subscription-based. And this is something our group has worked on with another project funded by CMS, where we provide the health information exchange with a list of patients in an automated way. And the health information exchange then does surveillance to see if these patients show up in another hospital for an ED visit or get admitted or discharged, and then they send us a real-time notification. And this is something that's in place in many health information exchanges now across the country. And, we've done this in the ED. It's been done in a primary care environment. One of the federally qualified health clinics that participates in HealthX receives these notifications, and we actually published a paper on adoption among family practice providers regarding these types of notifications. And Home Care, Visiting Nurse Service of New York, was one of the first organizations to really ask for this because, again, as you can imagine, if a patient winds up coming to the ED in the middle of the night, they want to know about it before they have the nurse show up at their house the next day unnecessarily for a visit when there's nobody home. But now we're starting to look more at what I like to call analytics-based models. So, the frequent ED user notification service is one of these. Rather than providing them with a list of patients, we're actually having the health information exchange implement criteria, inclusion and exclusion criteria, where they actually monitor for patients who meet those criteria and then create notifications based on that. And there's other potential low-hanging fruit for this also, things like 30-day readmissions or CT alerts. This is something that we are in the process of trying to develop a project for right now, where if a provider is ordering a CAT scan in real time in the EHR at our site, a web services call will be done to the health information exchange to see if that patient has had a prior CT, either exact same CT or a similar CT done at any of the other sites that do CTs. And if they have, an alert will come up in real time before the order is actually executed to tell the provider that they've had these prior studies done and potentially avoid unnecessary duplicate CT scans. So this is a slide just to remind me this is from one of our other notification papers. So when we receive notifications at Sinai, and we're in the process of implementing this for the frequent ED user use case as well, they come into our interface engine and they get split off into a number of different pathways. First, they get sent as a secure email to the secure email addresses of the care coordination team that's involved in the project. They also get sent to the IP zone phones as a text message for the practitioners who are currently working. They also get sent to a file on a server, on a secure server, so that we can do analyses on the data. And they get sent to our electronic health record, and they get put in as a pooled in-basket message for members of the care coordination team. And they also generate an actual encounter in the electronic health record. So people that are not on the care coordination team in the future can look back and see, and they're going in as what's called a telephone encounter right now, that the patient has had a visit to another hospital's ED, been admitted as an inpatient or discharged from another hospital. Okay, so then this is just a screenshot of those three things, the ways that we are able to send these notifications out, the text message on the bottom, an email on the right, and a screenshot of the in-basket notification on the left. And with that, I'll end. I'm happy to take any questions at the end of the webinar, and I'm happy to have anyone send me an email with any further questions. Thank you very much.
Well, thank you, Dr. Shapiro. And as a reminder, as he said, we'll take his questions after the end of the presentations. Please submit those questions using the Q&A panel to your right. And now we'll prepare for our final presentation. That's by Dr. Joshua Vest, and I can introduce him. Dr. Vest is an associate professor of health policy and management at the Indiana University Richard M. Fairbanks School of Public Health in Indianapolis, Indiana, and an affiliated scientist with the Regan Street Institute. A health services researcher, Dr. Vest's research focuses on the organizational determinants and effectiveness of health information technologies and systems. Most of his work is focused on the adoption, utilization, and policy issues of technologies that facilitate the sharing of patient information between different organizations, that is health information exchange. His 50-plus peer-reviewed publications have employed a variety of research techniques from large-scale database analyses to geographical information system mapping, to survey research, to qualitative focus groups and interviews. His work has been funded by the Agency for Healthcare Research and Quality, the National Cancer Institute, the Robert Wood Johnson Foundation, as well as by other foundations and state governments. So I think we need to go to the next slide by Dr. Vest. And welcome, Dr. Vest.
Howdy, y'all. I'm going to be talking to y'all today about the geography of community health information organizations in the U.S. This work was funded by AHRQ, and a full version of these results are currently online at Healthcare Management Review, and that in a forthcoming issue will be available. So community health information organizations, or HIOs, these entities, these collaborative working groups, collaborative organizations, provide a region or a state with the technical infrastructure and collaborative governance necessary for health information exchange. HIOs perform several services. They support reconciling patient identity across sites, locating records across different EHR systems. They maintain directories of providers. They route electronic messages. And they're an important component of the healthcare system because they've received significant public and private financing, and they're listed as part of the Federal Health Information Technology Strategy to achieve widespread adoption of health information exchange. An interesting feature of these organizations is that geography is a long-standing long-standing organizing feature. Many collaborative endeavors use geography and a common geography to organize their activities, but this is very true in community HIOs. If we just go through the kind of history of how these organizations have been labeled in the past: community health information management systems, community health information networks, local regional information infrastructures, regional health information organizations, or the RIOs that we're very familiar with. State designated entities are also have a geographical component to them. But the question is out there, is geography an effective organizing principle for community HIOs? And there's some indication there's actually some practical challenges with using geography to organize these activities. For one, community HIOs report serving an area. Generally, that area is defined by a political boundary, whether it's a state, a city, a community, a region, or group of counties. But evidence suggests, and we know that patients travel very far to get care. We often have patients cross that boundary into other areas. The map up on the top left comes from work that was done in New York City by one of our colleagues on the presentation today, and you see that for this New York City exchange, you have a lot of patients coming from multiple states and well beyond kind of the service area that the organization has said they're going to serve. Also, because of a very disparate developmental history and multiple streams of funding, states may actually have multiple and overlapping community HIOs. Here's an example there on the slide for you. one area, one city, a community had a long-standing community HIO activity going on. Later, a different funding mechanism came along and another one was established. However, they both purport to serve the same area. And we also know that not all areas of the United States have had community HIOs operating them at the time. Things have changed slightly with the advent of state-designated entities, but for a long time, there was areas of the country where no HIOs were actively going on. So all of these things can question whether or not geography is an effective organizing principle. If we think about duplication of effort, unavailable services, extreme variation in population served could all undermine goals of improved quality of care, more efficient care, safer care, and even public health. And to be on to boot, this can just make the daily operation of community HIOs that much more difficult. So to better understand information exchange activity in the U.S., this project sought to answer a couple of fundamental questions. First, I was interested in how frequently do community HIOs self-reported geographic service areas overlap or leave gaps in the U.S.? And second, I was interested in how do the areas community health information organizations report serving compare with areas from where their patients actually seek care. Now, I'm going to go through these steps in detail to give you an idea, but this is just an overview. To answer these questions, I first created an inventory of HIOs in the U.S., and we tried to face validate it. I did a GIS or mapping analysis based on the areas the organization said they served, their self-reported geographies, and then I looked at the healthcare markets they actually served. Now, on the previous slide, I kind of dropped two terms here that I want to be clear about. I am looking at first self-reported service areas. Community HIOs, as we said, it's a long-standing feature that they say they serve a particular community or geography. That's what we're looking at. Self-reported is what the HIO claims to be serving, who they say is within their catchment area or service area. The second definition is a market-based service area, and this is going to be the actual healthcare markets that are included in the HIO's activities. All right, so first, to do this, I first had to create an inventory of HIOs in the nation. I compiled various lists from different researchers and different organizations. We went through, deduplified the list, removed organizations that were no longer operational, things that did not fit our definition of a community HIO. We then reviewed websites to pull extra data on these organizations, what they were reporting, and we did all this in consultation with representatives from HIMSS who had been convening several working groups around health information exchange activities, so they had a nice insider knowledge. However, I wanted an extra level of assurance on the validity of our data set, so I tried a crowdsourcing effort as a validity exercise. So I created a public website and advertised it through multiple listservs and groups and shared it out. And once you went to this website, a user could see an HIO, they could interact with it, they could click on the geography, they could see what area it purported to serve, then they could pull up extra little information that we had also collected, like the number of participating hospitals, health systems, public health agency participation, clinics, those kind of information. They were able to go through that. And lastly, users were invited to submit feedback on the data and also edits. This was approved by the IRB, just for your information. So the public comment period ran for 45 days, during which it was accessed by 260 different users or different viewers. And the feedback resulted in 30 geography edits, actually 3 updates to HIO organizations, either removal or addition, and we got nearly 200 participating organization updates. So we ended up quite editing the number of hospitals that were participating in each organization quite substantially. And this is what the world looks like. I class the HIOs as either sub-state or state and multi-state together. That's kind of a standard approach several evaluators have taken. And a quick glance at this map of kind of self-reported world gives you a quick overview of some different approaches going on across the nation. For example, New York, Pennsylvania, New Jersey, Texas, California, Georgia are all network of network approach type states. You can see they're trying to link the sub-state exchanges together. Others are generally single health information organizations like Alabama, Mississippi, Arkansas, and some out west. Some are combinations. So this is kind of what our world looks like for us to begin with. And so far I've been dealing solely with the self-reported service areas, the areas the HIOs say they serve. That's on this map. Now I'm going to look at the markets actually served by the HIOs. And to get from self-reported service area to actual service areas, I aggregated the hospital service areas, or HSAs, of each HIO member hospital. So HSAs are from the Dartmouth Atlas, and they are the local markets for hospital services. They're the zip codes from which each hospital gets the majority of their patients, and it serves as a nice marker of a hospital's healthcare market, the market they operate in. And in this approach that I'm going to step you through, the HIOs don't say what areas they serve. They serve the areas that are served by their participating hospitals. The HIOs areas are the areas that are the markets of their participating hospitals. So I'll step you through an example to give you an idea of what this looks like. On the left of the screen, we have two HIOs, a red and a green. Red HIO, green HIO, and they are parallel against a common political border, like a state. The red HIO states they serve all the areas to the left of the line, and the green HIO says they serve all of the area to the right of the line. And you can also see the participating hospitals in each HIO's area. Those are the different little colored dots, the reds with the red, the green with the green. And the outlines are the actual markets for each of those hospitals, the markets that they're located in. Now, what I'm going to do is ignore the self-reported political boundary and say if the hospital participates in your exchange or your HIO, that hospital's market area is your market area, and I'm going to aggregate them up. That turns the geography into the figure on the right. This redraws the border between the two HIOs because an individual hospital markets can cross that political border. That's why it starts becoming jagged. And we also can see how the market area definition can differ from the self-reported area, particularly in the case of the green HIO. Within that HIO self-reported area, there are some hospitals that were participants, those would be the green circles, and some that were not. And for this example, I use the black circles. Because those black circles don't participate in the green HIO, the green HIO doesn't get to claim their markets in their overall area. So even though the green HIOs would say, yes, we serve everybody to the right side of that line, they don't get to claim it because they don't have any participants in those market areas. And so you can see the kind of gaps that grow up. Now we go through all of that on a national level, and this is what we end up with. This is what I would term as the coverage of HIO activity in the U.S. actually looks like. And I should put this in, these data are a couple of years old now, so things have changed. This was a snapshot in time. Now, this variance in definition, I think, introduces some important changes that are worth noting. First, all the HIOs tend to get, well, not all, but the HIOs tend to get smaller in terms of actual square miles served. This is much more pronounced in the state-level HIOs. Basically, HIO activity is not as widespread as we would believe simply looking at the self-reported areas. Interestingly, about a quarter of the sub-state HIOs actually get bigger. They have more market areas than they would purport to serve, but it's only about a quarter of them. You can also see gaps. That's all the white space. Some of these are very sparsely populated areas, like out west, but for several places that boast a statewide HIO organization, most of the state is not included. I don't want to call anybody out, but if you look towards the eastern seaboard, you can see substantial amounts of gaps. Thirdly, the HIOs cease respecting political boundaries. So if the self-reported service area is a state or a county, that all stops. And the HIOs start crossing into new additional states and to new areas. You can also see that significant overlap between the efforts still remains. And lastly, I don't present numbers on this, but it's in the full paper. We also saw that hospitals do not always participate in every available HIO. So if you have more than one HIO was offering services in an area, only about half the time the hospital would only join one of their choices, and about half the time they would join all the choices. But generally, we do have hospitals only picking one HIO to work with. So what the overall findings were that HIOs overlap service areas, and geographical complexity, I think, increases by accounting for participation in healthcare markets. There are more implications to than these findings, but these are the big ones that come to my mind. First, the occurrence of overlapping efforts creates the risk of incomplete information. The theory of health information exchange, if you will, is that better access to comprehensive, complete patient information at the point of care creates benefits. Well, with all the overlap and potential differential participation between HIOs by hospitals, we can't guarantee that information will be comprehensive, mostly because HIO to HIO exchange is still pretty rare. We also see, quite importantly, that this limits the availability for HIOs to support public health. Public health agencies need a census. They need data on all of their population. But we have several features that will make getting population data difficult. We have gaps. We have public health organizations are going to have to connect to multiple HIOs, even within their state. And then we have the need for crossing state boundaries. All those features are going to make getting comprehensive data for public health purposes that much harder. And the actual market areas served by HIOs create some policy challenges. Most notable is the fact that states can differ in their approaches to HIO participation. Some states are opt-in, some states are opt-out, and it even gets more complex in terms of who can see a patient record, in terms of credentialing, and who can't, and what you do with minors. You know, HIOs set up their marketing campaigns and their technology specifications around these policies, and there's a good chance, looking at the data this way, that many of these are dealing with patients who come from areas that are actually being governed by other policies. So in conclusion, community HIO coverage raises concerns about incomplete patient information and challenges public health agencies' attempts to collect community-wide information. Thank you all for your attention, and I want to thank several folks at the bottom of that slide who made this project possible through various levels of assistance. And as our other colleagues have said, this is my contact information, and I am more than happy to answer questions and be contacted by email as well. So thank you.
Well, thank you, Dr. Vest, and thanks to all of our presenters for their very informative presentations. And that concludes the content portion of the webinar, and we have a good amount of remaining time for questions. So as a reminder, you can type them into the Q&A section of the WebEx portal to your right. You may not be able to get to all of them, but we will do our best and try to answer them all either verbally or in writing. Answers will be sent to all attendees from ones that we weren't able to address during the webinar. So I'm going to go through some of these questions that people have submitted already, and we've got some good ones. And so actually the first question is going to go back to Dr. Cummins. So Molly, this one's for you. This question is around sustainability. And so the question is, how do you envision the service that you developed to be sustained after the grant period? Or how could other HIEs replicate it, given that poison control centers and public health agencies often don't have the funds to buy software or services from HIEs? So that's for you, Molly.
Okay. Can you hear me? Am I off mute?
We can hear you.
Okay, great. So this is a very interesting question. It's a very good question. Of course, the study itself is designed to answer some of the relevant value questions. For example, if you're trying to make a value case to a healthcare organization, you have to understand what this process does to offer them value. So we're looking at measures like door to MD orders, time to case closure, some of the basic measures that can demonstrate value and efficiency and throughput in the emergency department setting. Hospitals and healthcare organizations are generally very supportive of poison centers because they have that gatekeeper function. Some ideas have been floated, like assigning a very small dollar amount to each HIE case, charging that back to healthcare facilities for poison center services, because of course the poison center doesn't bill the hospitals for their services. So a very small fee attached to each HIE case may be quite reasonable. Now, from the poison center perspective, it's a little different. Every poison control center has a unique funding model. They're all funded differently. For example, in Utah, it's a line item in the higher ed budget, the state higher ed budget, and previously it was funded by a tax on telephone lines. Every state is a little different, but often, poison centers, the amount of funding they receive is tied to the number of cases they handle, and there's a real potential for this process to increase utilization, which would then increase funding to the poison control center. And then there are more aspects of this I suppose we can discuss, but I'd be happy to talk more offline.
Thanks, Molly. Let's go to so maybe a question for Jason, so Dr. Shapiro. This question has a little bit more to do with the data and the value you're getting from the HIE data. And this question is what conditions are causing high utilization among super ED users? That's data that you are gathering, and I wonder if you could tell us about that. And sort of the follow-up to that is, are EDs being used for services that could be performed in a physician's office?
Okay, those are very good questions. I think there remain large access to care issues that lead patients to go to the ED, and they're not able to get access to a primary care provider. And a lot of it is actually patient preference for convenience care. They can't take time off of work to make an appointment, or they can't get an appointment for several days, and they're able to go in to the ED and really have sort of one-stop shopping, perhaps in the evening or after hours, that allows them to get care that they would otherwise have been able to get from a primary care physician. In emergency medicine, I think a lot of people like to say emergency is defined by the patient, but we do wind up seeing a lot of patients in emergency departments that probably could be cared for in a different venue of care, whether it's their primary care provider's office or an urgent care clinic or somewhere else. And we're in the midst of a major crowding crisis in most emergency departments across the country. So figuring out ways to sort of decant the ED and take patients who might be better cared for and more appropriately cared for in other environments is a major goal. And, these patients that we're trying to identify in this study, the frequent ED user patients, the super users, a lot of it is trying to get them hooked up with case management, trying to figure out what is the reason for the recidivism and what other services do we have available that we could offer them to provide them with better care in other places.
Thanks, Jason. Just got a question that I think is a great one. It's a bit broad, but it really is addressed to all of you for your insights about health information exchange in general. And the question is and maybe we'll start with you, Dr. Vest. The question is, where are we going in the next few years? What do you anticipate will change, improve, or get worse in the next few years? And I suppose you could put that in the context of your own project, but also sort of more broadly, your insights would be, I think, interesting to our audience. So maybe we'll start with Dr. Vest.
So my track record of telling the future isn't that good, but I'll give it a shot. So I think the future is an increased reliance on health information exchange and the organizations that facilitate it. We are seeing dramatic shifts in terms of policy and emphasis in population health management. Jason mentioned these as a use case in his slides. We are looking at the real need to manage and address patient care across settings of care, being financially responsible or at risk for events that occur outside of a health system's own institutions. So there needs to be a mechanism to start following people, and I think the reimbursement strategies are starting to, there may be a ways away from them yet, but the reimbursement that we are progressing towards those type of reimbursement strategies that will make this kind of technology or these examples of technology really required and fundamental for any healthcare organization.
Great, thank you. And I wonder, maybe we'll go back to Molly. Do you have thoughts on this, Molly?
Of course.
We're not hearing you. I wonder if you could comment on where you think we're going to go in the next few years with health information exchange.
Sorry, I think I'm here now.
Okay.
I think that we're going to, as we move into real world use cases, we're going to see more integration. And certainly that's something, might be wishful thinking on my part. But health information exchange, it's just, I think I made the point, it's not enough to just move it, to just have it in a database where someone can log in. You actually have to make it available and meaningful to the healthcare providers themselves. And I think we're going there. The recent round of funding from the ONC seemed to be really focused on making that data matter. And so I think we're going to be seeing increasing use cases, and along with that, tools and models for making it happen.
No, that's great. Jason, maybe you can weigh in as well.
Sure, I'm happy to. You know, I would like to echo everything that both Molly and Josh have said. You know, I think increasing levels of aggregation, you know, looking at Josh's map, having fewer white space, and better integrated delivery of the information within the workflow, pushing the data to the clinicians so that they are aware of it. You know, adoption and usage remain large problems for clinical portal-based HIE, where the clinician has to go and perform a separate lookup and see if there's data available. You know, we're looking in our exchange at ways of really pushing the relevant data right into the clinician's workflow so that they're able to take action on it. You know, I think there's lots of things that can be done to further optimize the way that we're utilizing the information.
Yeah. You know, along those lines, there's another question here, and maybe Jason, we can start with you. The question is, you know, do you know what percentage of HIEs can actually provide structured data? So, for example, C-CDA structure, you know, for electronic import field to field, right, into the provider's EHRs, rather than providing a portal so that you search the PDF or Word documents, right? So getting something directly into the provider's EHR so that it is more, I'm sort of extrapolating from the question a bit, but so it's more amenable to provider workflow in a structured field as opposed to PDF or Word document.
Yeah, that's a great question. I don't know what percentage of HIEs across the country are doing that. I know that ours is, and I know that many others are looking at trying to integrate data directly into the electronic health record by having structured data come directly from the HIE. It's a bit tricky to do that. There becomes sometimes a bit of a versioning issue with documents that are being sent from the HIE, and there hasn't been a lot of normalization of the data, things like reference ranges across laboratories and things like that ahead of time. It can get a bit tricky to do, but I think ultimately it should really be transparent to the physician. The data should follow the patient wherever they go, and relevant information for that patient should be accessible and in a structured format that is actionable, both by the clinician and by things like clinical decision support and algorithms from the system.
Yeah. Josh or Molly, do you have a sense of the percentage of things that can go directly into as a structured way back into the EHR from the HIE in your settings?
So I'll start first. I agree with Jason. I don't know of a percent, but that is the kind of standard operating procedure that is expected to occur. But I will also kind of not only echo Jason's it's difficult, but I'm going to add the other thing of it's also politically and organizationally challenging. As a country, we haven't really figured out how much we are going to trust that sort of information being brought in to electronic medical records. A lot of organizations that I work with now can receive structured messages, and they get structured messages, but it's not wholesale dumps into their EHRs. It's either kept somewhere aside in kind of a holding tank pattern, or they're very, very curated and manually reviewed pieces of information before being brought in. So there's a whole host of organizational and even legal questions that still are out there about how we're going to reach what I wholeheartedly agree with Jason's vision of this kind of the information should follow the patient everywhere. But there's those challenges in front of that still.
Yeah. Molly, I just want to make sure you have a chance. Is there anything you wanted to add or experience you've had on this?
Sure. Again, I don't think we have a statistic, but I would say it's very uncommon. It's very uncommon. Healthcare organizations seem to keep the HIE data cordoned off, and it is not commonly integrated into electronic health records.
Mm-hmm. We've got a few relatively specific questions. I'm going to go back up to some of these. For Molly, for example, maybe two quick questions. One is the Utah HIE involved in the poison use case? And is your project supporting anything, so Cerner, but any other EHR vendors?
Sure. So the Utah Health Information Network is the middleman for our process. They are very much involved in this work on both the AHRQ study and the ONC project. And not only that, but they're helping to support sustainability of this process beyond the AHRQ grant by hosting the HISP for the direct exchange process and providing some other infrastructure support in a way that's going to allow the Poison Control Center to continue with this model after the grant has ended. So yes, Utah Health Information Network, and as a noun, if we're using HIE as a noun, we call it our CHI. That's our repository, and we'll be populating the CHI with these consultation notes. So, and then in terms of Cerner, of course, for the AHRQ grant is a scientific study. We're doing a lot of development work and implementation work, but we're actually measuring the effect of a workflow integrated process. And to study that, we have to integrate it with a system. And the system in this case happens to be Cerner. But the project is bigger than that workflow integration piece. And most of the tools we're developing are really agnostic, and we're creating them in a standards-based fashion, so they should be replicable in other settings. We're also making the software that we're developing freely available for non-commercial use after it's packaged up and ready to go. So we're creating very generalizable tools that will allow other settings to adopt this process.
Great, thank you. I think this question maybe is directed to Josh, and it's a specific question around urgent care centers. Do many of them connect to and contribute to the health information exchanges that you're seeing?
So in the experience that I've had, yes, but predominantly if they're an urgent care center that's associated with a health system. So the health system runs the urgent care center. To be honest with that, beyond that, I don't really know. I haven't looked to see if any other urgent care centers are associated.
Mm-hmm. And Jason, how about for you? Are you including urgent care centers in terms of frequent visits or just ED?
Well, in terms of frequent visit measurement, I was only looking at ED. In terms of urgent care participation, yeah, I mean, similar to what Josh said, urgent cares that are affiliated with current participants are definitely contributing data and utilizing HIE in our environment. Standalone urgent cares, I don't know of any that are currently participating. There may be, but I'm not aware in our exchange.
And Jason, I'm going to stay with you for this one. There's a question around, I'm going to try to summarize some of the background parts before the question, and it has to do with really new value-based payment models, right, that are seeking to, I'm paraphrasing the questioner, divert patients from the ED to the outpatient setting, right, so avoiding hospital admission and readmission and so forth. And the dilemma is that emergency physicians don't fit easily into that model, and so they may be left in continuing to be a fee-for-service type of model. And so there's a bit of a disconnect potentially. And so the question is how to evolve from this pay-for-volume to pay-for-value system without jeopardizing critical functions such as safety net, disaster preparedness, and rural care, and specifically the Emergency Medical Treatment and Labor Act, which I'm not familiar with, maybe you are. But this question is really around transitioning from volume to value in the context of health information exchange. In the context of health information exchange, I'm not sure, in terms of trying to make that transition in terms of reimbursement. I think health information exchange holds a lot of promise to try and decrease crowding and, move patients out of the ED, but in terms of reimbursement models that are based on volume right now, it might be counter to that. I don't really have a great answer in terms of how to make that transition for emergency medicine as a whole. I think new payment models are evolving, and trying to find a way of moving towards value in the way that we're reimbursed in emergency medicine is, something I know people are working on, but that's not something I've looked at myself. Mm-hmm. Josh or Molly, any thoughts on this one around health information exchange and how it fits in from change from fee-for-service to fee-for-value?
So I'm not going to speak globally. I'm not going to speak globally, not on the emergency department side, but globally. Health information exchange, the use cases of avoiding, all the examples you mentioned are things that people are at financial risk for. Hospital readmission, that's a ding, right? Getting poor quality measures, that's a ding. HIE can help with that. Doing prediction and risk stratification and tailored identification of at-risk patients, as we saw today, HIE is necessary for those kinds of things too. So that goes back to my first point when we first started the Q&A was the incentives are coming forward that are going to make this kind of a requirement for most healthcare organizations to be able to undertake this kind of patient and population monitoring, assessment, and following.
Mm-hmm.
Yeah, I just wanted, this is Jason, just to echo something that Josh just mentioned. I mean, one scenario, and this doesn't necessarily accrue to emergency medicine, but trying to prevent 30-day readmissions, receiving a notification that a patient has arrived in the ED that is a potential 30-day readmit is something that, we're trying to do. It's sort of the 11th hour opportunity to, potentially avoid a preventable readmission. So, that has some bearing on the emergency department, but I don't think necessarily directly affects ED reimbursement.
It's interesting. We have a fellow in the Utah Poison Control Center who's been using the Utah HIE on a pool basis to go back and look at the availability of information that would allow them to complete some reports that they're required to prepare. And it's interesting, in accessing that information, they're finding a lot of data that would have been very relevant during that poisoning emergency. And so, to me, that's just a real-world case example of how HIE can impact patient outcomes. There's also some, I just saw it in an abstract in PubMed, talking about how patients in the emergency department setting with poor outcomes could have benefited from better monitoring. Monitoring would have been a factor in the outcome. So at least in the Poison Center, we see sort of on-the-ground evidence of the ability to impact value. And it makes sense that it would do that at the system level.
We are, I think, 1 minute shy of our 2 p.m. start time, so I'm actually going to stop the Q&A portion there. Thank you all to those who submitted questions that I mentioned. We'll try to answer those either verbally or in writing to the ones we did not get to. This is the end of our Time River webinar, so again, thank you all for attending. For those interested in obtaining continuing education credit for participating in the webinar, please visit the URL shown on this slide. And there you will select today's webinar, which will be indicated by date and title, and then complete a brief evaluation of the event to claim your credits. You'll have 60 days to claim your credit for participating in this webinar. Upon exiting today's webinar, AHRQ is also fielding a brief evaluation, and we hope that you will complete the survey to share your feedback with us. Thank you all very much for participating in this webinar today. We hope you will join us for future learning opportunities. And we once again thank our participants and as well as our presenters, and we will see you next time. Thank you.